Well, welcome everyone to the 27th Degree with Chris and Nancy, current topics and best solutions. And today we're going to talk about hospice. And with me, I have two guests Kay Walker, who is the Director of Patient Care Services at Accent Care Hospice, and Tricia Blowers, who is a family member of a number of hospice patients in the past, I believe, correct?
Yes. Yep.
So we're going to start, I think we'll start just talking about what hospice is, just so everyone is kind of on the same page as to what hospice offers. So maybe you can talk about that a bit, Kay.
Sure. So thanks for having me here. So hospice is end-of-life care that focuses on a patient who has a terminal illness and they've decided that they want quality and comfort in their life instead of seeking more treatment. So then we come in as a hospice team, which is you are a medical director, nurses, chaplains, volunteers, social workers, a whole group of us to make the patient and the family comfortable with end-of-life situations.
Good.
Okay, I'm going to back it up just a little bit more
Sure.
too, because I don't know a lot about you. So can you
Sure.
just kind of go through your journey and how you ended up in hospice?
Sure. So I've been a nurse for 28 years.
Okay.
In hospice for 15. I trained at St. Elizabeth's for
Yeah.
nursing school. I got out. I worked at St. Elizabeth's for 5 years, and I worked on regular general medical surgical floors, saw all different kinds of patients, saw lots and lots of people come in with end-of-life issues, but nobody talked about it. So this is way back, in the early
Right.
90s,
Right.
and it was, you'd say, oh, he has cancer, isn't that too bad? But we're going to do this, we're going to do this, we're going to do this. And people were so sick, or congestive heart failure, any life-limiting illness, and nobody would bring it up. And I used to drive home, I used to work the night shift, drive home and say, there's got to be a better way. There has to be a better way for someone to end their life, or someone's life to end, I should say.
Right.
And it just was so shocking to me that we never talked about it. And I used to equate it to myself. I used to say, when someone has a baby, we're thrilled. Everyone's so happy. It's such a joyous time. Yes, is death sad? Of course it's sad. But why does it have to be painful? And, you see your loved one in pain. That hurts. And you say, how, they passed away. Oh, it was terrible. You don't want to hear that. So sooner rather than later, I started hearing about hospice, thinking about hospice. Fast forward, my dad was really, really sick. He had congestive heart failure. The doctor finally said, have you ever thought of hospice? Sure enough, we did. Hospice came in, and it was as sad as it was to see my dad pass away, it was the most beautiful death. He was home with us. He was able to enjoy his grandchildren. We had conversations that we wanted to have that you probably wouldn't have had if he really wasn't at end of life. And hospice kind of encouraged those. They were able to give us a little bit of a timeline with him. So it was absolutely the right decision that we had.
I'm a nurse too. I don't know if you realize that
Right.
or not, but I remember when we were in school getting trained, and throughout my first years, it was kind of the same kind of
Yeah.
situation. Hospice just wasn't mainstream.
Yeah.
It seemed like a lot of people weren't talking about it when the settings that I was in.
Right.
The hospital settings and things like that. It became a little more available and a little more known,
Right.
as time evolved. Was that your experience too,
So,
as medical
so
director?
my experience as a physician has been similar in a way. So, I went to medical school, 1989. So, and I finished.
That's a long time ago.
It was a long time ago. Right. So I finished my medical school training in '93. Went to residency after that. Started practice in '97. But when I was in medical school, there wasn't really any great education on how to deal
Right.
with death and dying. In fact, I think it was almost looked at as a failure when the patient died. So we would do everything we could up until that point, and then when you got to the point where it was very clear that there was nothing else to do to cure the disease or save the patient, no one knew what to do, really. So I have this really vivid memory. I was an intern at the University of Massachusetts Medical School, and during my internship, and I think during my medical school there, I had a rotation where I did an outpatient clinic. And there was a gentleman that I met who's, of course, has since passed away. His name was Fred. And Fred was like everyone's favorite grandfather. So he had congestive heart failure. He had a severe aortic stenosis or narrowing of the aortic valve. And he would come into the clinic every month, and I got to know him very well. And I looked forward to seeing Fred, and you know, we developed a close relationship. And this, you know, I knew him over the span of, you know, probably about a year. So fast forward, I was out of that clinic, and I was now an intern. And I was in the worst possible job that an intern can have, which is night float. So what night float is they have, depending on the size of the hospital, usually one doctor who's newly out of medical school, and they have him cover for the night shift. And you're basically covering the entire hospital in every emergency and anything that comes on. So at that point, it was even blood draws. If someone needed a nasogastric tube, whatever they needed, we did. So we were just running around all day and all night doing this stuff. And then as far as, you know, how interns are viewed, it may be different now, but back then the only thing lower on the totem pole than an intern was a medical student. But the medical students were somewhat protected. You know, they didn't really get abused as much. They got abused a little bit by the residents and the interns, but the interns got abused by everyone. So when you were night float, literally all you did was run around doing things, and you didn't have a second to stop. So I got called to this room to see this patient who was in pain. And I walked in, and it was Fred. I didn't even know he was in the hospital, of course, because he was on another service, and I was just doing this night float job, which was basically covering everyone. I didn't have my own group of patients as night float. You just covered everyone, right? When you're an intern during the day rotations, you have a panel of patients you follow. It's not that way with night float. So I go in, and I was shocked it was Fred, and he was clearly at the end of the road. He wasn't even really that aware at that point. But he was clearly suffering. You know, he had a lot of respiratory distress. He was pretty much obtunded, not aware of anyone around him, but he was breathing hard and really working to breathe and suffering. So, you know, I talked to the nurse. We got some morphine orders, and I sat with him. And I sat with him for, you know, quite a while. You know, as long as I could, probably got paged about 40 times in between, but, you know, I sat with him until I was clear he was comfortable. And during that time, and I brought up the part about how kind of interns are treated, because during that time, the nurse did something remarkable. I was sitting there, and she brought me in a cup of coffee. And I said, well, this is odd. I'm used to being abused. Why is someone being nice to me? And so she, you know, afterwards I talked to her, and she said, you know, that's the first time that a doctor has ever done that. It's ever an intern, certainly, or a resident, because you're busy. It's the first time anyone's really sat with someone who was dying. So then I started to think about that, and I thought, well, isn't this normal? Shouldn't we do this? Shouldn't we do this with patients who are at the end of their lives? And I started to realize that it wasn't the norm. That one, we had no training. Two, you know, like most human beings, we felt uncomfortable with death, and because we weren't trained to deal with it, we didn't know really what to do. So I became interested in trying to help people out towards the end of life. And I felt very comfortable talking about these things with patients. So fast forward, I finished my residency. I became a primary care doc. And then at some point, I had an opportunity to be a hospice medical director, and I did that. And then I went back for a second board certification in hospice and palliative care. And, you know, I think that, you know, now we're much better at this as a society. We understand the importance of talking about death and talking about, you know, one's condition towards the end, but it was not that way 25 years ago, as you can,
right.
you know, also,
Absolutely.
you know, have mentioned. So I think to me, it seemed like there was a need there. That's basically all that this is. I was coming around to say is I felt that there was a need, and there just weren't many people who were comfortable with it. And I was comfortable with it, so I went in that direction as part of my career, at least.
Tricia, I'm going to swing over to you for a minute now. As someone who used hospice services, talk about that journey and what that was like with your family member.
So I've actually done it in a couple different ways. My mother had like an early onset Alzheimer's, was in an assisted living, and then towards the last, 6 to 8 months of her life ended up in a nursing facility. And I actually, she was struggling. She was struggling with pain. She was kind of struggling with, she was still a little bit aware of like close family members, but you know, it was all new people, and she was just really having a hard time. And actually, I had talked to Kay because I worked with Kay at the time, and I said, you know, my mom's having all these issues and this pain stuff and this and that, and I don't really feel comfortable with how they're managing it and dealing with it, and it's making me really upset, and it's, you know, my family's upset. So she said, you know, she would qualify for hospice, and it didn't dawn on me in the nursing facility that you could do that. And I said, oh my God, that sounds amazing. So we ended up getting Hospice in, and it was the best choice ever for her, for us. We knew that somebody extra was there. She had her own personal care aide that came in and made, you know, took care of her. She had a nurse coming in that would manage her medicine and then call us and say, this is what we did. They took her off everything that was unnecessary and really, you know, just made her final months comfortable, peaceful. You know, they notified us anytime anything was happening. That was wonderful. And then my brother passed away about 7 years ago, and he had cancer, and he came for his last almost 3 months to live with me. And they gave him they said barely a month to live when he came with us, and he came home, and immediately we went on to hospice. And he, funny enough, lived much longer once hospice came in. They managed his pain so that he could eat, so that he was comfortable. He was walking around. He got to see everybody. You know, everybody was coming to see him, and he got to spend all this time with people that he really wouldn't have spent. You know, without it, it made me have somebody to be able to go to with any question. They responded immediately for pain, for anything, any kind of symptom he had. They immediately were there for us. When he was, really kind of close to the end, they immediately showed up also and just gave that support the entire time. And you didn't feel like you were alone.
So you had kind of two very different hospice situations.
Yeah.
Like here's your mom in a nursing facility.
Yeah.
Your brother was young.
My brother was 44. Yeah.
Oh, geez.
Yeah.
So, you're offering those services to her. Was it easy for him to hook up with hospice? Was it like a doctor referral? Like, what did that look like?
Yes, because at that point, even now, he was, he was, we had sort of said, I can't honestly remember if it was us or the doctor, but his oncologist was really wonderful.
Yeah.
They were great, and they really kind of helped that transition. He had gone into the hospital one last time, and, they said that was pretty much going to be like the last thing that they could do. So when he went home, it was just sort of an immediate transition. He went to a rehab facility for 2 days just so that we can get everything in the house that we needed for him.
Yeah.
And then we just went from there. And yeah.
I'm a hospice volunteer, and
My favorite people.
I know. I was just going to say, that was one of the wonderful things about the nursing facility is the hospice volunteers that would go in and just play music for her or put lotion on her hands or, I mean.
Those little things.
Those little things.
Give them their little stuffed animal and tuck them in
Or would notice a change. They would notice a change and say,
Yeah.
hey, I saw her doing this. Is this something
Right.
new? I haven't seen it before.
Yes.
To then prompt us to go out, and maybe it was a net adjustment, or maybe it was nothing, but it was just another set of eyes to take a look and report back.
And my experience has been like the patients that I sit with are comfortable with where they are right now. And granted, I only deal with the elderly population, but they're very comfortable. It's their families who struggle a little bit. So how do you make a family more comfortable? Like what, and I, like from your perspective, what do you do? And then what really worked with you? Like, what were those key phrases? And I'll have you think about this while Kay answers. But what were those key phrases or those little things that were done in the program that really made you go, like, warmed your heart and gave you those, like, moments that you're like, oh, my God, thank God for you?
Well, it's funny. I had a patient, a 65-year-old gentleman, that I was asked to go out and see one day, just for an informational. The family wanted to just hear about hospice.
Yeah.
He had esophageal cancer, lovely wife, lovely family. So I went out to talk to them, and I spoke to the husband and the wife, and he said, I'm pretty good. I'm good. I'm getting my chemo, I'm getting my radiation. I'm tired. but I'm good. So we talked about hospice. I asked some questions. The wife said, do you mind if I leave for a minute? She goes, I have to pick up one of my grandchildren at the bus stop. And I said, no, I'll wait. So she left, and the husband said to me, he said, oh, okay, I feel terrible. He said, I get this, I get this pain. I'm exhausted from the chemo. And my doctor, his oncologist, who was fabulous, said, it's really not doing anything. He's like, but I'm not stopping. He's like, because I would never make my wife feel like I gave up. And I said, there are ways to talk to your wife. Have you talked to her? He was like, no. He's like, I say I'm going to fight. She says, you keep fighting, and that's how it's going to be.
Mm-hmm.
And I said, okay. I said, if I can help facilitate a conversation or anything I can do to help. He's like, give me a card, but we're going to leave it like this for now. And I said, that's fine.
Yeah.
So the wife came back, and we kind of finished up. And I said, again, reach out if you need anything, if you have questions. And the wife said, can I walk you to your car? And I said, sure. So she walks me to my car, and she said, please, how can you get through to him? I want him to stop the chemo, and he won't. He
Oh my
wants to
God.
fight. And I said, I think you better have a conversation. And I said, do you want me to help you? And she said, yeah. She said, I can't watch this anymore. He's, 3 or 4 days after chemo, exhausted, can't interact with the grandkids, our own children. He's in bed for dinner. It's just not the guy we know. And he had been a fire chief for years and lots of friends and people stopping by. She said he has no interest right after chemo. And she said, we know it's not helping. The physician had said it really isn't doing much, but we'll continue if you think it's helping a little bit. So he wanted to stop and wouldn't say it to her. She wanted him to stop, but didn't want him to feel like she was giving up on him.
Right.
So we had a little meeting, the three of us, and we signed him on the next day to hospice. And it was the most lovely journey, I'll say. I got to know them very well. She actually, after he passed, ended up becoming a hospice volunteer. But he had probably a good 4 months of family time.
Yeah.
And he was, I'm not going to say completely pain-free, but his pain was in much, much better control.
Yeah.
Mm-hmm.
He went to some of the Little League games, like things he was not able to do. And he passed very peacefully with his family around him. And he's always sticks in my brain because it was just a conversation that had to happen, and no one wanted to disappoint each other, so it was
Right.
something, let's just not talk about it instead. And it was even to this day, I still speak to the wife, and she said it was the best thing she had ever done because finally it was okay to talk about that
Right.
thing in the room that no one wanted to talk about.
Oh, yeah.
So,
Yeah, it's,
yeah.
it's really fascinating, but I think in hospice, and you agree, it's basically what you're saying is we're treating not only the patient but the family.
Oh, absolutely.
And then, as far as what we're doing is, we're treating not just the physical suffering, but a lot of patients and families have, emotional suffering,
Sure.
spiritual suffering, and that's actually the hard stuff to deal with. And our hospice
Exactly.
nurses and social workers and all those involved are amazing at doing that. The physical suffering can be complicated, but we can generally treat that with medications fairly easily. The other types of suffering is more challenging.
Absolutely.
Because sometimes it goes back, there are maybe years and years of issues, family dynamics, things that come up, problems that you have to address. I will say that I've been really impressed with my medical colleagues, how they've evolved over the last 25 years. We went, I think, medical education has changed. We've gone from probably not talking about this to really people understanding it and embracing it. And the oncologists that we work with, I think, are fabulous.
Absolutely.
They are very open with patients about where they are in their disease progression. I think many of the primary doctors have gotten really comfortable with this
Agree.
too. So I'm really, it warms my heart to know that that's happening, that things have changed, because it's important to talk about all these issues, and it's important to be able to not only treat the pain of the patient, but understand their other suffering and the family's suffering. And these are issues that require a lot of time and a lot of effort, but you can really make an impact on patients and families if you're able to delve into these issues and deal with them.
Absolutely. Sometimes there is estrangement in families,
Yep.
and sometimes we've had many patients that maybe didn't know they had a brother or a sister, and
Yeah.
if we can help facilitate and have
Right,
that come
right.
together, it's a much nicer ending.
I mean, the social workers are, they do an amazing job with a lot of really difficult situations
Absolutely,
in hospice. I mean, like you say, we've had patients who they're estranged from their family and now they're at the end. And, the worst thing that can happen is they don't make that reconciliation at the end. Once they're gone, the family still has to deal with the fact that they're gone.
Right.
And it's just so much better when there can be some type of discussion or reconciliation. And maybe it's not a complete reconciliation, right? But
Maybe
and it's
not,
not
but
always. I mean, you
it's not always
can't-
perfect.
It's not always perfect,
Right.
but we've seen situations where our social workers and our nurses have been able to help out with those really difficult situations. People have been estranged for 20 years and that.
I agree, and I think also spiritually,
Mm.
with some of our patients who will say, is God mad at me? Why did I get this
Right.
disease? Why me? Or, am I going to go to heaven? Or,
Right.
things like that. Or what's it like? Or should I, I should suffer because I wasn't a good person. We've heard all these
Yeah,
different
sure.
things from
Sure.
patients, and I think when a chaplain goes in,
Yep.
it just helps put somebody at ease, and they talk about their fears, even if it's
Yeah.
just to have someone listen to what your fears are. Because some
Right.
people say, I know this sounds stupid, and it's not.
It's not.
very real fears of someone who is
Right.
facing end of life.
So I think, what you're saying, and this is another point that's interesting for those who are listening, is hospice is more than, a nurse and a doctor. It's really an interdisciplinary team. So we have, as you mentioned, a social worker, a chaplain, volunteers, and a volunteer coordinator that runs that, the doctor, medical director, the nurses, and it's all of them together that are able to deal with the patient and the family's needs. And for those out there who don't know how this all works, we meet every week. Every single week we meet, the whole team. Now we meet virtually because of COVID, but we meet and we talk about the patients and we go through everything that may be going on with them and what their needs are, and then everyone interjects their ideas and we come up with a plan.
That's right. And the other person I want to add to that too is our home health aides.
Oh, the home health aides, yeah, we can't forget that. I mean, they're really instrumental,
Yep,
really
absolutely.
instrumental in helping out.
So,
Yeah.
Tricia,
Yeah.
what really helped you during these times? Like, what would hospice do? Like I said before, that really was like those things that impacted you, and it could have been the little things.
So I was very lucky to actually be, I worked for home care. I still work for home care, but I worked for home care for a very long time. And I worked with Kay. So I got a firsthand, understanding of it with our patients and just, from knowing her. So I kind of felt like if she's telling me, then I know it's, it's the right thing, it's the right time. So I was lucky to just have that interaction with her anyways. But then I knew like the nurses were coming in, they had their own nurse. They had their own same nurse. It didn't really get bounced around, which is, a big thing. They had their own home health aide, somebody that could come in and make sure that they, were cleaned up or sitting up or whatever it was they wanted to do or whatever they needed. And it was that same person all the time. And that made a big difference. And just to kind of feel that overall support, like there was always somebody around, no matter when you needed it.
You weren't going through it by yourself.
You weren't ever going by, by yourself. And, if like with my brother, just because it was in my house, if he needed somebody and, there's only so much sometimes you can say to your sister or, you know what I mean?
Right.
Or whatever it might be. And like, he could just have time to be able to say whatever he
Yeah.
needed to.
Yeah.
And it also gave him a little more encouragement to be able to say whatever he wanted to us. Like it's,
Right.
He had a young son at the time too. And, and it sort of helped him manage that as well, because that was a whole nother, situation involved in that, and having, to not be able
Sure.
to know that you're going to, leave a young child.
Yeah.
So, I mean, but oh, sorry, I was just going to say, and then also afterwards, after that they passed away, that wasn't the end of it. Like they then still called
That's
us.
a really important
That's a-
point.
yeah, that's
We,
a
were-
great
you know what I mean?
point.
Like they followed up on us and made
Right.
sure we were okay. And
Yeah.
even like a year later, are you okay? Is everything okay? We just want to know, how you're doing. And so, I mean, it's not like they pass away and then, you're
Right.
sort of on your own.
Right.
It wasn't. Like they all still followed up with us.
Yep. You can probably speak to that a little bit, Nancy. I mean, okay.
Yeah,
Okay.
yeah, we do. We follow patients' families for 13 months after the
Yes.
death. We want to make sure we speak to them for the birthdays, the first Christmas, the first Thanksgiving, anything that's a big anniversaries, anything that's big in their life, we'd like to touch base with them,
Yep.
and we also give them, obviously, our phone number, and they can call when they're having a difficult time. If we think someone's having more of a difficult time, it needs bigger help than hospice, we would always, of course, refer them to someone that could
Mhm.
help them in the grieving process. But in general, we follow, like I said, all the families for 13 months, and a lot of times you'll see someone will say, "No, I'm good," because in the beginning you're very busy, you're making arrangements, you're selling houses or whatever you're doing when someone passes away. They're very busy. No, I'm good, and then about 3 months later, kind of everyone's gone back to their work schedules, and
Right.
families have gone home, and now you really are sitting with the fact that you lost,
Right.
mom, dad, or brother, sister,
It hits.
and it hits you. And
Yep.
that's when you get that phone call, just checking in. That's usually when we'll hear, I'm having a harder time than I thought I would.
Yeah.
It's usually around the 3-month mark.
And if someone's on hospice even for just one day, we
Right.
still do it.
Absolutely.
I mean, there's no timeline where, they have to be on for a period of time. We have a lot of patients who come into the hospital who are dying, and they have pain needs that need to be addressed. They're put on hospice. They die within a day, and we still follow up.
Absolutely.
So let me throw out a question to all of you. I'd like to get all your perspective on this. There's
Sure.
patients that are offered hospice and like, no, not going to do it.
Yeah, well, you
Um,
mean that we can't do it, or?
No,
That
no,
they
no.
don't want
That
to.
they don't want it.
Yeah.
They're having
Sure.
a problem with the diagnosis.
Yeah, yeah.
Don't talk to me about hospice.
Right.
What are some tools and things that could help a family in that scenario? Like the family maybe wants hospice and very
Right.
badly,
Back
and the
and forth.
patient's like, no way. Like I don't know how your brother
that-
was being so young that did he just jump on hospice right
So
away?
so he did. He our grandmother had been on it previously,
Yeah.
so he had seen it. He did working in the medical field. He trusted me with that stuff too.
Yeah,
You know what I
yeah,
mean?
yeah.
And he, we had a conversation about it and sort of what that looks like and how it actually is usually better and
Right.
always better actually. You know what I mean? And I do find that patients just because I see them before they sort of transition.
Right.
Everybody's like, it's almost like they feel like, oh well, if I go on hospice, I'm gonna die. Like,
Right.
it
Right.
immediately makes it happen tomorrow.
Yeah.
Instead of it actually, stretching it out. And even working in the healthcare field, it did not dawn on me that my mother was somebody that could be qualified to be on.
Right.
And it made a huge difference. And I mean, I was like, well, she's not gonna, she's not, because I was thinking it needed to be a closer time
Right.
period, and it doesn't.
Right. And that's a misconception.
That's a
that
very
people
big
have.
misconception.
Yeah.
So a lot of times just telling patients like, maybe you just want to have the hospice informational. They can explain it
Right.
to you. You don't need
Yeah.
to make any decisions. And we sort of transition it
Right.
that way and then try and get it in their hands, and then they know what they're
Yeah.
Yeah.
They're saying.
So, okay, then two questions really. Like going back to that, what do you tell a family? Like if someone's talking to you and like they're just not going to agree.
You know-
Like how do you support the family in that scenario?
It's all about the approach and how
Yeah.
you speak to someone. And sometimes they've just gotten the diagnosis 2 days ago,
Right.
and here you are, going to come and talk about hospice.
They're not
Maybe
ready.
they're just not ready.
Yeah.
So you can give them the information that they ask you for. I don't ever give them too much because you try to meet people where they are. Give them the information and say, why don't I call you in a couple of days and see how you're doing and see if you're ready. Call back. Sometimes they say, can you come back? I have more questions. Sure. Or sometimes I still don't want you to come. That's fine too. So it's just about checking in with family,
Yep.
and it's everyone's so individualized in how they're handling their
Right.
situation. But it's just about being consistent to let them know you're there. You're there for whatever. And sometimes people don't ever come on. But
So
it's
and when
about-
they never come on, like what can the family do to really make that dying situation as good as they can for the patient? Like what would you tell a family that won't have hospice services? Communication, I'm hearing
Right.
from some of these conversation
yeah.
threads, is super important. But what else
I
can
mean,
a family?
they have to communicate very well with their primary physician, because at that point they would be the one that would be, pretty much running the show, so
Right.
to speak, providing the medications and everything that's needed. But I think that's very limiting, because now you're without the a social worker, without the aides, without volunteer coordinators, and I think there's less that's available. There's less support that's available, so it can be difficult. It can be difficult, but there are a lot of patients who don't choose hospice for a variety of reasons.
Right.
And,
So what are the most helpful things for the family that's not going to have the hospice services? Like what to make that patient transition, you know?
You know, I think the most important thing is to reach out to their physician, obviously, who's going to try to
Yeah.
really guide them.
Right.
And sometimes, a lot of times, Nancy, if the patient didn't want it, if they're so ill at the very, very end, the family member will make the decision to say,
Right.
you know what, I do want you
Right.
to come now.
Right.
And
Right.
usually we'll have that patient on probably 24 hours,
Yeah.
which, like Chris said, they don't get the benefit of the whole team.
Right.
Right.
Because really we're in there quickly trying to get symptoms managed and have the patient be comfortable.
Yeah.
So it's much, much better, of course, if we're able to be in there 6 months prior and
Right.
have the whole team and have a really nice kind of journey with the patient. But if it is that way, 9 times out of 10, a family will say, I didn't realize it was going to be this, because now the patient is, whether they're unresponsive or they're in a lot of pain,
Right.
that poor family member is like, what do I do? They're so nervous and they don't want to see their loved one in pain,
Right.
so they will reach out. But again, it's like in the last
Yeah.
24 hours and you're really trying to
Right.
scramble and get everything done.
I think a lot of times there's patients, families don't know what to expect, and that becomes the problem.
Right.
So I think a lot of the responsibility falls on us as physicians. You know, we need to be open and communicate with our patients about what they should expect, and we should be talking to them about healthcare proxies and what we call MOST forms, which are basically advanced directive type forms telling us what they would like to have done. We have to have those conversations. Do you want life support? Do you want dialysis? Do you want these things that can be done or not? Once you start talking about that stuff, it opens up conversation to go in a lot of directions. But I'm amazed there are a fair amount of patients who end up in the hospital who haven't had these conversations, who have terminal illness, and that's unfortunate because as Kay mentioned, you know, they sometimes end up there in extremis and really with extreme symptoms, and we can do things to control the pain, but you know, there's a lot more we could have done if we were there earlier.
Tricia, how did your family dynamics change with, you know, hospice being in? Did your family unit, did it get stronger? Were there issues that came up that you didn't agree on, and what did that look like?
It was, you know, there's always issues
Yeah.
with family sometimes, not necessarily family, but sometimes, you know, other people. So you know, whoever he wanted to come in, we
Right.
let in.
Right.
It may not have been our favorite person all the time. It may not have been whatever. But honestly, you know, that just sort of, it was, you know, it was all about him. That's what
Yeah.
that's what it was. For that you know, period of time, we're like, this is what we're doing. This is, you know, we're going to make the best out of all of it. We're going to get every minute we can.
Right.
You know, and luckily, you know, he really did extremely well on hospice. That he was up and moving and walking around until maybe 2 days before he passed away. I mean, it was amazing. So he went from being in the hospital and barely being able to get out of bed to coming home and walking around with a walker, and he'd sit out on my deck, and you know, he'd have all kinds of people be able to come over and visit with him. And you know, my other brother and I, you know, my husband, we just sort of all came together and said, okay, because I was still working. I had taken a little bit of a leave, but I was still working, and we just all split it up. I mean, my mother-in-law, my brother, like my niece, everybody, we just all took shifts so that he was not by himself.
So you have children. How
I do.
did you explain the concept of death to your kids?
So I didn't have them then. One of mine was born about a month and a half after he passed away. They know about him. He's there, you know, we talk about it all the time. But you know, that he's in heaven. My mom's in heaven. They did know my mom they were very little, but they did know my mom. So we do talk about it all the time, and that, you know, they're sort of, you know, always around us, and you know, that kind of stuff. But it's hard. I mean, it's hard to explain it to them and be able to do it on their level. So as they've gotten older, like there's pictures of him and my mom in the house, and you know, we just sort of go with it, and they ask, you know, where he is, and is he okay, and is he happy, and you know, and kind of go with that as they get older, and guiding the conversation.
Yeah.
The other thing, if I could just kind of backtrack, was that made a big difference also is with hospice, is once he came to my house, I wasn't ready for a person that was sick to be living there. So they brought everything. Like I had a hospital bed and, you know, commode and shower chairs, and everything that we needed came with him. and they got that ready right as he was coming in. So that made a humongous difference too, because we had everything he needed. He had a walker, he had everything he needed in that short period of time.
That's really important. Kay, can you go over the qualifications? Because I don't think the
Sure.
majority of people
I think a lot of people think hospice, they think it's for cancer patients. Like
Yeah.
it's only for cancer patients, and it's not. Of course, it is for people with cancer. But we have diagnosis, Alzheimer's disease, COPD, congestive heart failure, kidney failure. So there are a lot of different, each diagnosis has different qualifications. They're not something that's really set in stone. We've had patients that maybe don't meet, so Medicare gives us the guidelines. Maybe someone doesn't meet every single qualification, but they've changed dramatically in 6 months.
Mm-hmm.
We talk about that. We talk about that as nurses to the medical director, to the team. They might say, my mom, has a diagnosis of Alzheimer's, and maybe she's still speaking words, but maybe 6 months ago she could read the newspaper and have a conversation. She doesn't do any of that anymore. So now she's changed. So we go in, we evaluate the patient, talk about the diagnosis, speak to our medical director, decide what is the best way. Do they meet? Do they qualify? Now, sometimes people don't qualify at that time.
Yep.
So you might see someone the beginning of May, and they just, they're not quite ready for hospice, and maybe they're ready, but they don't qualify yet. So what we say to the family is, can we come back in a couple of weeks, evaluate again? Maybe they don't qualify then. Can we come back again? And sure enough, they usually do qualify by then.
What are the major qualifiers? Like what buckets do you have to fall into?
So, for an Alzheimer's patient, let's say.
Yeah, it depends on the diagnosis.
Yeah,
really.
so like an Alzheimer's patient, have they stopped walking? Are they incontinent of bowel and bladder? Do they speak anymore? And if they do, does it make sense? Again, there's so many different kind of qualifications of people for depending on the diagnosis. Someone with congestive heart failure, are they on oxygen? Are they short of breath while speaking to somebody?
Talk about the perception that hospice is only for people that have 6 months to live.
So that's an interesting thing. So I have to certify patients who go on hospice, and I have to say that if the natural course of their disease were to run as expected, that they would live for 6 months or less. However, we have patients on hospice that are alive, a year later or more. So it's not as if you get to that 6 month mark and the person is still doing well, that you have to take them off hospice and, oh, you really messed up, you didn't get it right. I mean, Medicare is cognizant of the fact that physicians, we are limited in our ability to predict when people die. We have a sense, and we have a sense of how the natural course of the disease will go, but everyone is different. We have to recertify patients periodically. So we'll do the initial cert, and let's say someone has heart failure, and they have what we call New York Heart Association Class 4 heart failure, meaning they're short of breath at rest. Okay, they speak, they're short of breath. They're sitting there, they're short of breath. They meet the criteria. We put them on. It's expected they will not survive 6 months. We have to recertify them as time goes on. If they're stable, then it can become a problem, but usually there's something that happens. There's another issue, they decline in some way, and then, they can, 9 months from now, they can still be on hospice, because there is that gradual decline. Same thing with Alzheimer's patients or cancer patients. Not everyone kind of follows a plan. So, and that's okay. That's all right. We want our hospice patients to have the best quality of life that they can have and be with us as long as they can.
Absolutely.
Okay, as director, so you're going into COVID, and can you talk about the communication you had and the changes you had to make, and what was like? How were you successful in the transition into the new COVID world?
So it was interesting.
Sure.
It came pretty quickly. We really just, before we go out to a family, we speak to them. Even if we see them twice a week, we get asked the same questions. Has anyone been exposed to COVID? Has anyone traveled? Does anyone have these symptoms before we go into the house? We go into the house anyway with a mask on, always, of course, washing our hands, using gloves when we're taking care of the patient. If someone says, yes, my son just came back from Florida and he has symptoms, what we've been able to do is do some virtual visits until that person has had a test and it has come back negative. And it's amazing how quickly we kind of adapted to the virtual visits. The family we have like an iPad, and the family brings a phone right into the patient. We can look at them, we can assess them, we can talk to them, how are you feeling?
Yeah.
And they understand why.
Right.
Because of what we're going through right now. If we've had a patient, if one of our actual patients, we've been in the house and taking care of them, and they start to exhibit symptoms themselves, we will go in full gear. If they need us, we'll do as many virtual visits, but if they do need us to go visit them, we will go in with, face shields and our masks and gowns and gloves, and if they really need us to go in and see them. But most of the time we can advise the family over the phone, and again, we're able to see them on our iPad and give them the best care that they need.
Thank God. So as a leader now, like if you had to speak to other leaders about what made you very successful and how you communicated with your staff and any other processes that you had to change, what would you say to other leaders out there that might be struggling with this transition and are working with a staff who's scared?
Right. And I've had many staff members who are, of course, very afraid.
Sure.
I think the first thing that I do is listen to them, listen to their feelings and validate them, because it is scary. We've had different families that have had, people have traveled and things like that, and they're like, I have kids at home, Kay, I don't want to go in that house. And then we just talk about it, when we say we're going to follow the guidelines of the CDC, we're going to protect ourselves the best we can. And a lot of times they'll say, I'll see the patient at the end of my day, then I can go home and take my shower and kind of make themselves feel better. So we develop a plan that works for them and works for the family. But I think listening to people, and, I did hear someone say to somebody one time, you're a nurse, you signed up for this. Well, you know what? We all have families at home, and we all have things that we don't want people to be getting ill because of us. So it's important to listen and validate.
Absolutely.
And
I
come
don't
up
think
with
we
a
ever
plan.
expected it to be a pandemic.
Right.
It would be
Right,
doctors or
exactly,
nurses.
exactly.
So it's still stressful,
Yeah.
and we
Oh,
have to
absolutely.
validate that
And it's
stress.
stressful for any leader going through this transition, I think that's where we would come in, Chris, and it's
Yeah.
like really working with any organization
Right.
or any company to really guide them through those changes
Right.
and help them with the strategies that they need to focus on to be successful during the reopening stage.
And I do say, Nancy, like I have to say, with Accent Care, who I worked for,
Yeah.
they were diligent about PPE. We were very, I know that there were so many, you hear
Yeah.
so many stories about people struggling to get PPE.
Yes.
And I do have to say, we have enough PPE. No one has gone ever without. We have a surplus just to be ready,
Yes.
because people are saying, it comes in waves, and you don't kind of know what's going to happen.
Right.
But it's been very comforting to know that we have plenty of equipment to protect everybody.
Right.
That's great too.
Yeah.
So just going back to the staff communication, because again, I think communication is just one of those pillars of successful transitions with anything.
Mhm.
Would you say that too? I mean, you've been on both sides.
Yes, most definitely.
It's like that communication is so important. I mean,
Right.
what was the best pathway when you reopened your office that you looked at to really get messaging out to your staff and everything?
Well, when we reopened, we only had, we didn't bring back all of our staff, so there was a
Yeah.
lot of direct communication that occurred. The staff was small enough, we were able to do that. But I think you have to, this is all very new, and even though we've been doing it now for months, it's still new, and it's still scary. It's scary to a lot of people. You have to be able to have those open conversations with your staff. Kay is very good about communicating with her staff, and I think that's a key reason that she's been successful and the hospice has done so well. And we've been able to maintain and retain our staff for that reason. Where, if you don't communicate and if you don't talk about these fears, people leave, and then you're stuck without people to do the work that's so necessary. So, Kay is always talking to her staff. I do the same thing. We have meetings regularly, and you have to really listen. You have to listen to what they're saying and try to respond in a way that is supportive. I think that's all I can say about that.
Yeah. How big is your staff?
We have, for the whole team, we have about, I want to say between 16 and 20 with per diem nurses as well.
Mm.
Yeah, we have a really
Very
nice
good.
group.
What would you say? I'm just going to do a couple of closing questions.
Sure.
So for you, Dr. Junkus,
Yeah, go ahead.
what would you say to other physicians? You said that now that there's been an evolution, that
Right.
More doctors are aware of
Sure.
hospice and everything else. Do you
Right.
think those conversations are happening as much as they should?
Well, I think, I teach medical students from Brown, and I
Yeah.
think that they're getting the education they need, but I think there's still are some of us out there who haven't probably, received the education and probably don't feel comfortable. But, I would just say to my colleagues, just do your best to try to be comfortable with this. It's a part of everyone's life. We're all going to face this at some point. And I think if you really want to do your patients a service, you need to be comfortable with these conversations. And the other thing I would say is, have the conversations early. There's so much that we can do to benefit families and patients if we're involved early on in the process.
Mm-hmm.
When it's a day or two before their death, there's only so much we can do. And that's actually a lot of our admissions to hospice. It's a large amount. It's unfortunate because I look
Yeah.
at those patients and those families and I say, wow, we could have done so much more if we were involved earlier.
Right.
So I guess that would be a take-home point, is try to get the families and the patients involved earlier in the process.
And then Kay and Tricia, closing comments and like that key takeaway for anyone listening to today's podcast about hospice.
I would encourage people to reach out to their physicians if they think, sometimes if there's a physician who's maybe treating and not mentioning hospice and they kind of just, they've been with the
Yeah.
physician for 20, 30 years, and they just kind of go along. But if they're feeling, gosh, I don't want to go back to the hospital anymore, I'm tired of going back in, or I'm really tired of taking this medicine, have a conversation with your physician,
Yeah.
and they will guide you in the right direction.
Yeah, I agree.
I just think a big thing too is that for people to not think that by doing that they're giving up. I think they're actually taking
Yeah.
control.
Right.
Good point.
I think that
It's a great
the family
perspective.
members and the patients themselves, you get to take control. You get to take control of what your time's going to be like, how you're going to feel, as
That's
much
an
as
awesome
possible.
point.
But I mean, you get to take control. So I feel like a lot of people don't want to talk about it because they feel like they're giving up on that person they love, or they're giving up on themselves and they don't want to hurt the people around them. But I think it maximizes the time that you have with those
Right.
people that you love. And
Right.
it really,
Great point.
it's really an amazing thing, for people. It really is.
Yeah, it's really about having the best quality of life
Yeah.
for the life that you have left. And a
Absolutely.
lot of that, like you say, people lose control towards the end of their life.
Yeah.
Their physical, what's going on physically, emotionally, everything.
Yeah.
And we try to give that back to them.
It gives them a little bit of that
Give them a
sense
little
of like,
control and give them the best quality they can have. And the earlier you do that, the better.
most
Absolutely.
definitely.
That's great.
So Kay, if someone is interested in hospice, how do they get in touch with Accent Care?
So the most important thing is to have a conversation with their physician first, and then the physician's office will send us over a referral.
Okay, there you go. Easy,
Great.
Easy
Easy.
peasy.
easy.
All right. So we're gonna end with a song.
We will, and I was just going to say also to those who are listening out there, if you have topics that you would like us to discuss, please contact us. Please go to our Facebook page or go to our website. And Nancy and I were very involved in customer service, process improvement, patient experience. If your company has needs like that, we can help you out, and just reach out to us. But it's a tradition now, this is the second time we've done this, that we're going to end on a song,
I
so.
don't know if you knew about this.
So-
I did see one of the other ones. I like
All right,
that.
I will
That's good
apologize in
observation.
advance to anyone who has very sensitive ears out there. But I try to pick a song that is appropriate to the topic. So this is a Bob Dylan song. I'm
Nice.
kind of a big Bob Dylan fan. So we'll see how this goes. Hopefully it goes well. Really weird singing with a mask, by the way. May God bless and keep you always. May your wishes all come true. May you always do for others, let others do for you. May you build a ladder to the stars, climb on every rung. May you stay forever young, forever young, forever young. May you stay forever young. May you grow up to be righteous. May you grow up to be true. May you always know the truth. See the lights surrounding you. May you always be courageous. Stand upright and be strong. May you stay forever young, forever young, forever young. May you stay forever young. May your hands always be busy. May your feet always be swift. May you have a strong foundation when the winds of change shift. May your heart always be joyful. May your song always be sung. May you stay forever young, forever young, forever young. May you stay forever young. Thanks, everyone.